Welcome to a new lecture of the induction course for the Pediatric Cardiology residents. Today we will discuss follow-up of patients in the Pediatric Cardiology clinic. Patients following up in our clinic may be having a congenital cardiac defect or an acquired heart disease, cardiomyopathy, arrhythmia, and we have a population of post-cath or post-surgical patients. The scope of the Pediatric Cardiology Clinic follow-up is to follow up patients for any new complaints, which should be analyzed and managed accordingly. Also, we have to ensure at each visit the right dosing of medications, and we should refer patients to cath interventions or surgery if needed. In all patients at each visit, please ensure accepted weight gain. Stationary or decreasing weight might require an addition of a high caloric formula or consultation of the pediatric nutrition clinic. All patients under the age of 2 years should have vitamin D supplementation, and all those under 2 years should also receive iron supplementation starting from the age of 6 months. Patients following up in the cardiology clinic should be annually screened by echocardiography. For patients with congenital cardiac defects, patients with acyanotic heart disease at each visit should be checked up for absence of tachycardia, absence of tender hepatomegaly, ensuring a good capillary refill time which reflects good perfusion. Red flags in this subset of patients include tachypnea interfering with feeding, respiratory distress with retractions, mottling of skin, lethargy, decreased activity, or decreased oral intake. Also, a new onset of dusky discoloration is a red flag. In this subset of patients, please revise the anti-failure medications, the dosing, and the frequency of the drug intake. Patients might be on diuretics, including furosemide, which can be given once daily, every 12 hours, every 6 or every 4 hours. They might be receiving spironolactone, which can be given every 8 hours or can be given once daily and better to be after meals. Patients might be on captopril, which must be taken every 8 hours and better on empty stomach. Patients might be receiving digoxin, which is given once or twice daily with drug holiday, and those patients also might be receiving carvedilol. Please take care that patients with acyanotic heart disease and those with atrial septal defects we refer for closure, either percutaneous or surgical at the age of 2 years. Patients with ventricular septal defect must be closed if persistent after 7 years or earlier in presence of heart failure. Patients with common AV canal should be operated upon as early as possible. And also patients with BDA should be referred for percutaneous closure at the age of 6 months. And patients with semilunar valvular stenosis should be referred for dilatation if the peak gradient is exceeding 65 mm mercury. For patients with cyanotic heart disease, all of these patients need iron supplementation at 4 mg per kg per day. They also need supplementation with folic acid. If the patient's saturation is below 75%, this requires intervention. Please follow up these patients for signs and symptoms of polythysemia, which may include headache, dizziness, blurred vision, or dyspnea. That might require partial exchange transfusion. And please bear in mind that patients with tetralogy of Fallot should be referred for surgery at the age of 6 months. For patients with acquired heart disease, most importantly rheumatic heart disease, please ensure that these patients are not having new onset of fever, joint pain, or active arthritis. Please ensure they are not suffering any signs of heart failure, which might include muffled heart sounds or the presence of pericardial rub or a change in the character of the murmur. All these patients should receive long-acting penicillin every 2 weeks only after sensitivity testing, which must be done before each injection. For the penicillin sensitivity testing, 0.1 ml of penicillin is diluted in 10 ml of saline, and then again 0.1 ml of the new solution is injected intradermally. If there is no reaction, no erythema, no wheal formation within 30 minutes, then the injections are given deep intramuscular. Another subset of patients following up in the cardiology clinic include those with cardiomyopathy. These patients should be always followed for deterioration of heart failure or the presence of arrhythmia. History suggestive of palpitation warrants ECG and Holter monitoring, and anti-failure medication doses must be checked at each visit. Bear in mind that patients with severe dilated cardiomyopathy and reduced ejection fraction might be kept on low-dose aspirin 3 to 5 mg per kg per day. Additional drugs in this subset of patients might include new anti-failure medications like Entresto, and they may also be receiving Procurelin to control the heart rate. For patients with arrhythmia, all these patients should be followed up for symptoms suggestive of episodes of abnormal rhythm. ECG must be done at each visit, heart rate must be estimated, and the corrected QT interval must be calculated as it can be prolonged as a side effect of antiarrhythmic medications. Medications that might be used in this subset of patients including the propranolol, also the sotalol, and imidazole can be used in these patients. If the patient is kept on imidazole, please ensure to look for side effects of imidazole, which might affect the thyroid functions, might cause photosensitivity, peripheral neuropathy, can affect the lung with lung fibrosis, and also can cause to liver damage, and that's why liver functions must be followed up in these patients. For the post-surgical or post-CAS patients, following cath interventions, patients with closed ASDs or VSDs with device must be kept on low-dose aspirin for 6 months. They should be followed up by echocardiography 1 week post-intervention, and then 1 month afterwards, then after 3 months, 6 months, and at 1 year, and then they should be followed up by echo yearly. Also, patients with inserted stents must be kept on low-dose aspirin plus or minus clopidogrel, and they should be followed up by echocardiography every 3 months till surgical intervention. Patients with prosthetic valves must be kept on Marivan with a target INR ranging between 3 to 4, and this should be done every 2 weeks. Please bear in mind that there are 3 concentrations of the Marivan tablets: 1 mg, 3 mg, and 5 mg. And patients with previous Glenn shunt, they must be kept also on low-dose aspirin and should be referred for cath assessment and completion of Fontan at the age of 3 to 5 years. Thank you.